Thank you once again to the Honorable Minister of Mizoram for joining us. Thank you, sir. Thank you to the other distinguished dignitaries, to the Honorable Minister of Solomon Islands. Thank you, sir. So, ladies and gentlemen, this is a session on reaching at-risk populations, intersectoral collaborations and the whole of government approach. This is a session wherein we are going to be identifying the at-risk areas and populations and discuss innovative tools and approaches to reach them. Also discuss the role of intersectoral collaboration and the whole of government approach in reaching at-risk population, more inclusive approach, inclusive malaria elimination response in the Asia-Pacific region. I invite the distinguished chairs of the session. May I request Lady Roslyn Morauta, the Vice Chair, Global Fund and Board Member of the Asia-Pacific Leaders Malaria Alliance. May I request everyone to please settle down so that we can be more deep into this session. Inviting Ms. Jaya, the Additional Secretary, Ministry of Tribal Affairs, Government of India, our distinguished chair. I invite now our panel. Now, the structure of this session, ladies and gentlemen, is as the two chairs give their opening remarks. Post that, we are going to be having the experience sharing from the community, and then we are going to be having the panel discussion. So let me invite the panelists also to take center stage, inviting the moderator of the session, Dr. Ms. Shampa, the co-founder and steering committee member, Global Civil Society Network for Malaria Elimination, who has more than 22 years of extensive experience, professional and research experience in the health sector, with special emphasis on malaria control, elimination, and cross-cutting domains. May I request you, ma'am, to please grace the dais. Our panelist of this session, Dr. Corine Karema, the CEO, Rollback Malaria Partnership to End Malaria. Before joining the RBM, she served as the special advisor to the board chair of the Global Fund, which is a partnership designed to accelerate the end of AIDS, tuberculosis, and malaria as epidemics. She was earlier also the Malaria Senior Program Officer at the African Leaders Malaria Alliance. Our next esteemed panelist, Mr. Albino Bobogare, the Director, Vector-Borne Disease Control Program from the Solomon Islands. He has worked for the NVBDCV since 1989, from when the country was in transition from eradication efforts back to control and now towards elimination. He was the co-chair of the VXWG, and he ensured that the needs of the country partners are central to the working group's agenda. Our next panelist, Dr. Anupong Sujariyakul, the Senior Expert, Department of Disease Control, Ministry of Public Health, Thailand. His focus areas are communicable disease clusters and public health emergency preparedness and response. He has also served as a regional director of DDC to supervise public health office along the Thai-Myanmar border provinces and central Thailand to improve the communicable and non-communicable disease surveillance and control at the local level. So with our distinguished panelists and the stage set towards a session, I first request our Honorable Chair, Lady Roslyn Morauta, who's the Vice Chair of the Global Fund to Fight AIDS, Tuberculosis and Malaria, and board member of the APLMA. She has more than 4 decades of extensive experience in Papua New Guinea's public and private sectors, and she's worked in the PNG's National Planning Office as advisor to the Department of Finance before launching a career in the community work as PNG's First Lady in 1999. I request her for her opening remarks.
Thank you very much. And Excellencies and distinguished guests, sincere thanks to the Government of India for hosting this meeting, and special greetings to my Wontok from the Solomon Islands, Dr. Togamana, Minister for Health. Colleagues from WHO, the Rollback Malaria Partnership to End Malaria, Bill and Melinda Gates Foundation, and other partners, experts, friends, and honored guests, welcome to this session. As we heard in the last session, the malaria epidemiology in the Asia-Pacific region is complex and reflects its tremendous geographical, environmental, and biological diversity. From isolated islands in Papua New Guinea to forested tribal regions in India, malaria remains prevalent in diverse settings, particularly in regions with limited access to health care. To combat malaria effectively, interventions must be carefully strategized, grounded in districts and communities, and tailored to the needs of the most vulnerable and at-risk populations. In my view, it's essential to involve key populations in the design, implementation, and monitoring of health services, as well as in policy decisions that impact them. I'm pleased to see an increasing number of malaria programs in our region customizing their approaches to target high-risk populations effectively. In PNG, delivery of malaria control and diagnostic tools typically requires an aeroplane, helicopter, dinghy, canoe, or truck, and often days of walking. Yet we've been able to maintain nationwide distribution of LLINs. In Cambodia, malaria volunteers are traveling between up to 40 kilometers to reach the forest goers, undocumented migrants, and mobile communities. And in India, as part of the Malaria Mukt Basta Abhiyan, health teams conducted door-to-door screening in over 100 tribal blocks and adapted innovative approaches like ringing of bells for community awareness to use LLINs. Beyond the malaria programs, we're seeing non-health actors joining the fight against malaria. For example, engagement with school children in Cambodia as health messengers, data sharing by climate departments in the Solomon Islands, Vanuatu, and India, and cross-border collaboration between military and civilians in the greater Mekong countries to support their malaria responses. We must, however, remain vigilant as there are still regions and communities that continue to suffer from malaria. Humanitarian emergencies have further led to population displacement, food insecurity, and health system disruptions. In order to reach the 2030 goal of malaria elimination, it's more critical than ever to intensify efforts to reach vulnerable and hard-to-access populations, the last mile. This calls for concerted efforts from governments, bilateral and multilateral agencies, and community partners to address the underlying barriers and strengthen malaria responses. This conclave for malaria elimination provides us with an opportunity to further amplify the voices and priorities of at-risk communities. In this session, we'll be hearing from experts and practitioners who have experience in designing and implementing programs that target at-risk communities. I'm honored to chair this session with Ms. Jaya and look forward to a productive and engaging discussion. Thank you.
Thank you, Honourable Chair. And may I request now our second Honourable Chair, Ms. Jaya, the Additional Secretary, Ministry of Tribal Affairs, who brings with her extensive experience working with the community, engaging in women's empowerment through the formation, stabilization, and capacity building of self-help groups as the additional collector earlier. I request her for her remarks.
Thank you. The chair of the session, Lady Roslyn, our esteemed panelists, and all the experts participating in this conclave. First of all, thank you, both the Health Ministry and the organizers of the conclave, the Asia Pacific Leaders Malaria Alliance, for having called the Ministry of Tribal Affairs to this extremely, extremely important international event. Thank you for that. I come here as not only a representative of the Ministry of Tribal Affairs, but also as a spokesperson, if I may say so, for a very large group of people, nearly 100 million of them, forming about nearly 9% of the population of India, the scheduled tribe population, amongst whom malaria is a matter of concern. And some of the ways in which malaria affects them is because of their location. As we know, the scheduled tribe population of India is mostly residing in forested areas, in remote areas, with not too much of an access to medical care and medical health facilities. They have their own socio-religious, ethno-medicinal kind of practices, health practices which are unique to them. The traditional healers and the traditional systems of medicine and health and diet practices have their own influences on them. And therefore, it is quite a challenge to reach out to them when epidemics like malaria take place. And of course, there are certain habits, certain health practices that really help us too in ensuring that these kind of diseases don't spread. Nonetheless, it is a population which is vulnerable. It is a population which requires care when it comes to issues such as malaria. And this conclave, we hope, would be leading us to look into international practices, best practices that have worked in such populations, also a kind of learning about from our peers, from our experts on what can be done, what needs to be done. Our ministry, the Ministry of Tribal Affairs, has been closely working with the nodal ministry, the Ministry of Health and Family Welfare in the Government of India, on many matters involving tribal health and also on the epidemic of malaria in tribal areas. Of course, malaria is not specific or limited to tribal areas, I understand that. But then we are talking about the marginalized sections, how to look into their requirements. And I'm happy to say that both the ministries are working on a joint action plan that can be kind of looked into for implementing at a joint level, not only at the national level, not only at the central government level, but also at the state government levels, what many of us would be calling provincial governments in other parts of the world, and what we call the state governments in our country, which are having their own autonomy within their own spheres of administration and polity. But nonetheless, there is a robust connection between the state governments and the central government. There's a robust give and take in terms of both finances and in terms of experiences, in terms of learnings, in terms of cooperation. So the federal cooperation is a very strong concept in India, and drawing upon those kind of experiences and concepts, what we would like to do is to look into this joint action plan for a future where hopefully malaria will be eliminated from the country. So this is the aim of the conclave, and I'm happy to report here that we are looking into ways and means by which that becomes a reality by hopefully a very near future. So with that, I would just like to say that I think the entire strategy has to be in terms of a planning, a very robust evidence-based planning, followed by a very strong implementation mechanism, a monitoring and supervision mechanism which can lead to mid-course corrections, leading to feedback, again going back to a mid-course correction and a planning process which will take into account the learned experiences. And today, I think these learned experiences of this collective group here would certainly help us to formulate that evidence-based planning. With that, I would like to open the field to the panelists. Thank you all so much for having us here. Thank you.
Thank you, ma'am, for your opening remarks. And with that, we begin with our panel discussion and hand over to our moderator, Dr. Shampa.
Thank you, Vime. At the outset, I would like to thank Government of India as well as APLMA for giving me this opportunity to moderate this important panel discussion. With the permission of the chair, I would like to start this panel discussion. In fact, right from the morning, we have been hearing that, the communities, there are particular communities in remote areas who are the most affected and they remain vulnerable, and responses need to be tailored for them. We have also heard, from the distinguished dignitaries since morning that how whole of government approach, or whole of systems approach is the way forward, is one of the way forward apart from the core interventions. So from that perspective, we have eminent panelists here. We will be discussing that. And if we have time, we will take some, maybe 1 or 2 questions later on, because we are already running short of time. So without further ado, we are aware that malaria is a disease of poverty and inequity, with the most poor and marginalized communities at the greatest risk of affected by and even dying from malaria. In Asia Pacific, malaria strikes the hardest in vulnerable populations living in hard-to-reach remote areas, with difficulties in accessing health services and other services, including communication facilities. We have also seen in those areas the malaria interventions, malaria services, as well as surveillance systems are either non-existent or still deficient. In fact, such key and vulnerable populations, we have heard from Dr. Momo, that they really need to be catered to, and we need to tailor our responses like that, and equitable responses are the way forward, looking at addressing the community human rights and gender biases and inequities. In fact, a whole of government approach we have been hearing is needed to ensure the policies and strategies are aligned to support at-risk populations within the ambit of an enabling environment and more efficient and effective use of resources. Such approach has the power to enhance impact and foster sustainable solutions to end malaria, which we are all aspiring for, and also the theme of this event. To begin with, it would be great to hear about country policies and strategies in place to reach communities who remain at risk of malaria. I would like to invite Dr. Anupong and Dr. Albi, maybe first with Dr. Anupong, to tell us about the communities in your country that remain at risk of malaria, and what policies and strategies are being implemented for them, and what are the persistent challenges that still need to be addressed. Dr. Anupong, please.
Thank you, Mr. Moderator. Good afternoon, Sawadee Krap, Excellency and district participant, Madam Chair. First of all, I would like to thank the host country, India, and the Upper to invite me to join this important malaria conclave meeting. So, in this session, I think it should be really, because the first session is about the update and the challenge. So you may know about the challenge, the update from some country that present this morning. In Thailand case, I also would like to a little bit update and to say about the challenge. First, I would like to give you more understanding about the Thailand in terms of geographic. Thailand with 65 million population, and we have together 77 provinces, including Bangkok. Okay. In terms of administrative, we have the central level. It means minister and department level, and also division. And in the provincial level, provincial level is mostly appointed by the governor, appointed by the central level, and the lower government administrative is they have election and the 4-year term as a whatever they call like municipality, local administrative body, or even say Bangkok metropolitan area. Okay, and in Thailand also malaria situation. We right now in Thailand we so-called the forest malaria. It means that our malaria situation confined in the remote forest and the mountain area. In particularly the province along the border, right? For example, the Thai-Myanmar border, Cambodia, Thai-Cambodia border, Thai-Lao border. Recently, in the past 2 years, maybe the situation in malaria situation rising. So I would give you a little bit, in the past 2 decades, I would like to give you the number, like the number of malaria cases go down from 160,000 in 20, the year 2000, and it go down to only 2,000 cases a year. So, and the Thailand National Malaria Program starting move forward, move towards the malaria elimination since we have 2016 something. So it means that right now we have 46 provinces that declare and certify by the National Malaria Program. But 6 out of 46 provinces, they have reintroduction of malaria cases. Okay, so still a number of the provinces that have case reporting. But as I said that in particular the past 2 years, according to 6 provinces along the Thai-Myanmar, due to the civil unrest. So you know, and as a Momowin has talking about the situation in Myanmar border. So it means they have the at-risk population is not only the mobile population, that in fact of the refugee and the migration of the migrant, also the problem of the putting malaria become more cases during these 2 years. It's up from 2,000 right now is almost 10,000 a year. So that is a problem right now. So so we have our policy. Let's say that we have a strategic plan for the national malaria elimination. So we also facing some problem about the cross-border. So we have many things that still challenges for us to make. We also challenge for the preventing of the reintroduction and re-establishment of malaria cases. So I will stop here for a while.
Thank you. We do understand that, that there are some provinces where there has been a resurgence of malaria, and of course you have a problem with the border areas. I'd now like to listen from Solomon Islands. Definitely it's a high burden country, but how you are, at least at this juncture, can you just share with us what are the strategies, policies for, your at-risk populations you are implementing? Thank you.
Sorry. Good afternoon. Thank you, moderator. I would first of all like to acknowledge the support from for this meeting from the Apalma Upman team, and especially the government of India. Also, I would like to acknowledge the presence of our excellencies throughout the region, Asia Pacific, as well as our collaborative partners who will always be behind us in our endeavor to eliminate malaria. Thank you all for your continuous support. So I would like to share Solomon Islands' current status in terms of risks. Solomon Islands also have 10 provinces. Out of the 10, only one is free of malaria, as it has no vector within the island or that province. In terms of vulnerability, all the, including Polynesians, Micronesians, ethnic minorities, they have the same access to the services provided by the ministry as other citizens. And self-reported disability is remarkably consistent across provinces, with only one province a little bit higher range. Malaria is both an urban and rural disease affecting all age groups, all economic groups, and both sexes, men and women, with no apparent occupational gradient in incidence between men and women. Children less than 5 years of age account for only 18% of cases in the last years. So malaria is a disease of both adults and children. Transmission risks vary significantly between provinces and within provinces. Of the 45 health zones within the country, 24 have high annual parasite incidence, ranging from 80 to 300 cases per 1,000 population. That makes up 67% of the total population. They are primarily in 4 provinces, including the main city for the capital city of Solomon Islands. 8 health zones are classified as medium term and 12 as low. The 12 low API health zones are in 3 provinces, and these 3 provinces are low enough to enter pre-elimination. The ministry is currently implementing what we have developed as a role delineation policy to improve primary healthcare services delivery and ensure universal health coverage is achieved. At the program level, we are also including specific strategic planning for each province to engage existing community organizations within these provinces to be able to sustain partnership going into the future. The persistent challenges are those of health systems, including supply chain management, communication reporting capacity, appropriate human resourcing, and financing. And this is more importantly within the provinces. So going forward, I think the program needs a lot of intersectoral support to address these challenges and build up the strength in surveillance and response to the current high burden provinces. Thank you.
Thank you. In fact, it's good to know that, that apart from the strengthening of the program, involvement of community organizations and intersectoral approach, they are also being emphasized. currently, we know that the RBM Partnership to End Malaria is as a global platform of partners and stakeholders, and coordinated malaria responses is vital for them, and they are advocating consensus building and harmonized actions amongst them. So therefore, amongst other effective partnerships and data sharing are key priorities of RBM partnership. I would like to invite Dr. Corine Karema to share your views on these priorities. In addition, I would also like you to share what are some of the challenges around accurate data on the burden of malaria among at-risk populations, and can you provide examples from countries from your own experience? Thank you so much. Dr. Corine, please.
Thank you very much. So first of all, Excellency Ministers, government officials, Director of National Malaria Elimination Program, distinguished guests and partners, and I would like to recognize also the chair of the Global Fund, Lady Rose, and partners who are here. First of all, thank you very much for inviting and extending your invitation to the RBM Partnership to End Malaria. And I would like to congratulate the government of India as well as APMA for hosting this Asian Pacific Leaders Conclave on Malaria Elimination. So, as you know, we have made tremendous strides towards malaria elimination during the past 20 years, and large part is due to the increased availability of data. But as you know, malaria community still has a long way until we have the right data to enable us to target the fight against malaria in our communities, countries, and globally. And I'm really glad to be here because we see the Asian Pacific region as an example. We are inspired by this region because you are showing us that malaria elimination is possible. But of course, there are many challenges. I will just name few challenges regarding to the data. So the first one is weak surveillance system that usually leads us to suboptimal quality of data. As you know, most of the malaria data are estimated. We really need real data for us to target and achieve our target. The second one is we don't have always disaggregated data, and we are going to discuss that are required for us to target and know where the geography as well as the people and the target, the hard-to-reach communities are for us to tailor our malaria intervention. And then maybe the third one is weak capacity to analyze our data and make decisions. So we are collecting many data, but most of the countries are not really using them for decision making. So the good news is that countries and donors are really working together to make this happen. For instance, with the support of partners like the Bill and Melinda Gates Foundation, the Global Fund, under the leadership of the WHO, we are working with the HBHI, so the high burden, high impact countries, where we are using subnational tailoring to target and tailor the malaria control intervention. And then, of course, the whole back malaria has also understood the challenge and related to data for a long time. And in 2020, we have created the Malaria Matchbook Toolkit, which is a simple, low-cost, and innovative tool that allows countries to gather malaria-related data. So this toolkit is enabling countries not only to correlate their malaria epidemiological data, but to also look at what are the key social determinants of health and malaria. You have seen that today many speakers have said that malaria is not only health issues, but we really need to look at all the social and economic determinants. So the malaria matchbook tools is used by community health workers to allow them to record the key information related to each patient, which are then also disaggregated at a central level. So our goal is to help increase the reach and uptake of prevention and care services, particularly by the underserved population. So disaggregated data is really essential for us to identify geography, the people, as well as the population that are needed to be targeted. So we are making strides, and with continuous investment in health and surveillance, we are strengthening our responses to malaria. Thank you.
Thank you, Dr. Corine. You are very right, and you did mention that data-driven approaches are definitely, in planning and designing the programs and implementing, they're very crucial. In fact, you also mentioned about how in the HBHI approach of WHO and RBM partnership and other partners, sub-national tailoring is being, taken forward. You also mentioned about the malaria matchbox tools, which is an equity assessments tools. Not only it does epidemiological assessments, etc., but it also gives community human rights and gender assessment, and therefore it helps programs in shaping up equitable responses. I would like to now invite Dr. Anupong again to share his experience in using data to reach at-risk groups. Dr. Anupong, please.
Thank you. Yeah, I concur that data is very important for the planning, both epidemiology cases, detection, and the vector data are important. And because by principle, by this principle that we agree that in fight against malaria, we should have early detection and prompt treatment, and also have do some field work, like, for example, control response by using the 137 measure, and we have to know about the use of the RDT and the deploy of the LLITN or Bennett. So in Thailand, we have the application called the Malaria Online that allow us to have the trained malaria health worker in the remote forest area that can, when they diagnose or using RDT and malaria positive case, report at the village level. Trained malaria health volunteer is the same, quite the same as you may know about the village health volunteer in Thailand, that we have almost 1.2 million. But for the malaria health volunteer, this is in particular we have in the remote area that very specific to the malaria services. So they have trained about how to use the RDT and how to give the treatment, and also they collect the to report by a report using the Malaria Online, as I said. So the up level from the district and provincial level supervisor, they can monitor also in the by using the application Malaria Online. Yeah. So whenever the case come up, reported by the village level and the district public health officer or the provincial health officer, they will have some notify them to how someone to go to the outbreak investigation, to do the foresight management, something like that. So it's very powerful in using the Malaria Online in Thailand. Okay, so it means that we can see whenever the village, the very local, the local level that report, so the district level they know the situation and can give the supervision. So that is the use of the Malaria Online. And also they still have some indicator that we should monitor that. For example, the 137 control measure that they also, the supervisor also have to know that whether they apply or not. So they also really important. The number of the bed net, the number of the RDT used in every month, something like that. So that's in Thai case. Thank you.
Thank you. In fact, it's good to know that how at the local level the data is being used, and you also mentioned that the case-based surveillance data, they are being used for, sort of that kind of information for actually doing the focus response in a equitable manner in those areas. Moving forward, in fact, we heard that malaria is not a siloed program, and we've been discussing intersectoral cooperation, whole of systems approach, whole of government approach. In fact, right at the beginning, Madam Chair, Madam Roslyn, as well as Madam Jaya mentioned that how other sectors need to be involved in if we really want to end malaria. So drawing from that, I would like to now invite Dr. Albi to share his thoughts about how non-health sectors utilize disease-related information, such as the rates of malaria incidence, etc. And also, could you please share a few highlights from the MalaClim project in your country? It's a kind of a climate-related project which is being implemented in Solomon Islands. Yeah, Dr. Albi, please.
Thank you again. I will be brief. In the Solomon Islands, we do have data available. The stakeholders which usually utilize this data is the education, students learning, and the other departments and ministries. One example of the ministry which have worked with us using our data and their data combined, we build up a model, and this forecasting model is called MalaClim. It's a joint between malaria and climate data, which is basically rainfall. So this is a malaria forecasting model developed by these two ministries with support from DFAT some years back. And it involves sharing of many years and years of data, malaria data, and also rainfall data from the Ministry of Environment. It forecasts the chance of malaria to increase. Currently, we have trialed it in one zone, and we are still learning from it. But yeah, recently we have discussed the need to revise the model as the cases in that zone continue to rise. We have noted that there were some variables that were not considered in the model, and some of these are related to issues like supply chain management and this kind of issues. But there's a need, the use of the data that we are concerned about mostly is the use, the real-time data, which we are still yet to achieve. We are working on it with partners, but we are yet to have real-time data suitable enough for immediate response on high burden zones, and which will be very vital for surveillance and response when we move into pre-elimination and elimination. So that's I think what I can share for the moment. Thank you.
Thank you. It's good to hear that there is an innovation and malaria forecasting modeling being done along with the other other departments who handle the climate change related issues. In fact, I'm sure there are examples from each of the countries regarding intersectoral collaboration, and those are from time to time either published or also documented. I would now like to invite Dr. Corine again to share examples of successful coordination and collaboration across sectors and ministries that have helped to strengthen malaria services for vulnerable communities. And what are the key lessons learned from these successful collaborations? Dr. Corine, please.
Thank you very much. So as many speakers have said, we know that multi-sectoral collaboration is key into fighting malaria. And to deal with challenges like insecticide resistance, drug resistance, population growth and mobility, effect of climate change, and lack of funding, we must work across sectors to come up with solutions together. Because this is so important, the malaria community launched a multi-sectoral action framework last year to support countries to rethink. It's really very important that we try to change the way we have been doing business. We change our mindset so that we can push to move from a solely health sector approach to become more coordinated and bringing in expertise and actors from across various sectors such as agriculture, finance, education, and environment. So at the global level, the RBM Partnership to End Malaria plays a key role on multi-sectorial engagement. We coordinate a great variety of stakeholders that are involved in the fight against malaria, and our platform provides really many opportunities for information sharing, joint learning, and coordinated action on malaria. We also facilitate the knowledge sharing and best practice exchanges among different stakeholders. So to give some examples, I know that in this region there are many examples, like if we take Sri Lanka or Bhutan, as well as Timor-Leste. Those are the countries that have shown with their success they have been involving many sectors like education, agriculture, to fight against malaria. And in Africa, I can give the example of Zambia, where the government is collaborating with many sectors within the government, like health, education, and agriculture, as well as environment, so that they are able to implement an integrated community-based malaria control program to combine not only vector control, but also health education. And this example of collaboration is really showing impact. So in terms maybe on the, some important lessons learned. So first of all, the first one, number one, is it's really essential that leadership to committed to promoting collaboration is key. So prioritization of malaria at the highest level of government is often needed and is crucial to incentivize and facilitate coordination across sectors. The second one is we have seen in some countries specific mechanisms are put in place to facilitate coordination, such as, for instance, if I take the example of Rwanda, you have the interministerial group or task force that were involved in the mitigation plan to fight against malaria. So you had all the sectors, the defense, agriculture, education, and they were all working towards fighting malaria, and we have seen that thanks to that cross-sector collaboration, there was 80% reduction in malaria cases and death. And lastly, strategies and policy between ministries must be aligned. For example, as much as the prevention requires collaboration with either agriculture or environment, policies on vector control must also be shared across sectors. Thank you very much.
Thank you, Dr. Corine. Thank you for sharing examples from Sri Lanka, Bhutan, and Timor-Leste, and of course from Africa, Zambia. We do know that, yes, the collaborations are really important, and going forward, lessons learned from these countries would be good to disseminate so that other countries also learn from them. A key aspect is one of the major thing is, of course, we have been hearing the sustained and sufficient resources are really required for malaria elimination, and then, of course, prevention of reestablishment of malaria transmission. We have heard during the previous panel discussion as well, but then we would like to hear from the eminent panelists, especially from all three of you, just very quick comments regarding how the sustained and sufficient funding they are required, and for delivery of the strategies, not only in burden reduction, but also in elimination settings. So please, starting with maybe Dr. Anupam, and then Dr. LB, and then Dr. Corine. Very quick comments.
Yeah, thank you. I think before I start to touch about the Sustain Malaria program, I still hope to share a little bit about the intersectoral coordination in terms of the, I would like to say that when malaria as a vertical program, that's the job of the Ministry of Health. But after we have the additional funding from the Global Fund, it allows us to have more body like CSO, the private sector to come to join the program. And also we are in the mode of the decentralization. The local government in Thailand have growing, and they have their own budgeting. So we lessen the domestic budgeting at that time, because we know that the Global Fund is not last long, because Thailand may be as a middle income country, though not eligible for the Global Fund. But however, we still have we have the problem with cross-border collaboration, cross-border problems. So we still can have funding from the Global Fund in terms of live project something. So COVID-19 also show us that intersectoral collaboration and bigger picture that multi-sectoral collaboration, and also not only the public, also private and civil and the civil society. So that is whole of government approach and the whole of society approach. So I just would like to share a little bit. We have also raising the Plasmodium noci cases. That also allow us to working together from Ministry of Public Health and the Ministry of Environment, because parasite Plasmodium noci is a zoonotic malaria. So we are also working very closely to the forestry, Department of Forestry. Okay. So this, how to sustain the malaria program, I think the funding is, the financing, I think I heard this morning also touched a little bit about this. I think this is also very important to continue as funding, because when we go to the last mile elimination, it's very difficult, and domestic funding is not enough. So in my point of view, I think the additional from the regional fund or from the international donor and joint hand partnership with the all relevant sector, CSO, are need to strengthen the malaria elimination. So I think we still have room to strengthen our program until we achieve our target. Let's say that in Thailand, we would like to elimination our malaria to malaria by 2024. But according to the situation, maybe we cannot achieve by 2024. But however, by 2030, I think it's almost reasonable time. So that's it, my point of view. Thank you.
Yeah, Dr. Alvi, please.
Yes. Again, as you've learned, for us in the Solomons, we still have a lot of work to focus on the high burden provinces to reduce malaria, and before we think of going into pre-elimination. At the moment, we are working with all the provinces with funding from Global Fund, as well as the government. We are working very hard with we have worked with the Prime Minister's office previously since 2018 to develop a roadmap for malaria elimination. Unfortunately, all our plans to really make a difference was disturbed by the COVID in 2019 up to last year. So we are starting again to work, starting with the ministry, executive, to revive our plans for under the roadmap. And I think we are still also working hard to engage the support from other partners besides Global Fund and the DFAT. We are looking to seek more inter-collaboration with other partners to move forward with our efforts to bring down the high burden zones and start work and establishing the task force within the government to be able to ensure that the resources that are required to make a difference for the different provinces, different zones, is well advocated and understood by everyone within the country, from the political level right down to the village level. That's all I can comment. Thank you.
Thank you. Dr. Corine, quick comments, please.
Yeah, thank you very much. So we need to know that we have less than 50% of the global malaria funding that is needed for us to get back on track. Of course, the Global Fund has helped a lot. As you know, we didn't achieve the target that we wanted. We wanted 18 billion for the Global Fund. We only reached 15.7 billion. So with these funding shortfalls, what is important is we need to change the way we have been doing business. We need to prioritize and optimize the current resources. And for me to do what we need is to do more with less money. Efficiency is really very important, efficiencies as well as effectiveness of our work. Of course, we also need to increase the synergies. So we have seen that with the COVID-19, it's really important to invest in the health system. And of course, while investing in malaria, this should also be a pathway of investing for the health system strengthening, as well as for future pandemics. And then, of course, as the previous speakers say, we need to increase donors as well as domestic funding. Of course, it's important to know that we are within a difficult context, the economic hardship, but the most important is efficiencies, value for money, to do more with less, and that will help us to achieve and end malaria. Thank you.
Thank you. Yes, we do understand that, efficient utilization and value for money are critical elements. We know the resources are definitely not so, optimal as yet. But at the same time, more and more increased investments from the in-country investments, that is the domestic resources, are important, while the Global Fund definitely is continuing to support the countries in a big manner along with the other partners like PMI, WHO, etc. Now we have come to the kind of end of this session. I'm not so sure whether we have space for question and answer, so we would just directly go to maybe one or two questions from the August gathering here. If you would like to ask just one or two questions, please, and kindly first, introduce yourselves, and then you can please identify which panelist you would like to ask the question to. So, any question from the audience? Yes, please.
It's more a comment, if I may, and I'll try and keep it short. It's based on an observation that was made this morning. Sorry, my name's Leo Braak, Appman Vector Control Working Group. And it was based on the comment about the shortage of medical entomologists globally. So, just a reminder to all of us that the primary strategy for malaria control is vector control. And vector control, it depends on effective vector surveillance. Just think bed nets and monitoring and management of insecticide resistance and so on. So this is a global problem of shortage of entomological skills, and it's not going to go away. In Asia, we're very fortunate in all the countries having been very effective in reducing the burden, but as the malaria burden declines, so the arbovirus burden is increasing. And you are still going to need entomological skills when malaria is gone. So I'd like to make a plea that, this problem really needs to be confronted head on. And there's a shortage of institutions that provide training at undergraduate level for entomology. So I just want to make that observation and maybe ask Dr. Anupong if he has a comment or two to make in response. Thank you.
Yeah, thank you very much. In fact, it is, I'm sure each of the program who are running the country programs, they know that this is entomologists are kind of the vanishing tribes, and therefore it is, but then it is definitely one of the core intervention which is really required going forward, even if the malaria elimination is there, but beyond that as well. Any other question, please? Yeah, Dr. Roop.
Yeah, thank you very much. So I have a question for rollback malaria, Dr. Corine. The high burden, high impact approaches, which is led by WHO as well as the rollback malaria, and in India we have implemented in 5 states. And what we have found, there is a reduction of cases, and the approach that includes the political will, strategic situation analysis. Then we have to develop the action plan, better coordination mechanism, and also the better guidance, policy guideline dissemination. I think it includes all the factors, all the components which are required for the malaria elimination. So we are planning to implement only in the high burden area. Why not we can think about even in low burden area? So what is your view?
Yeah, thank you very much. So this was an initiative that was developed in collaboration, so RBM, Partnership to End Malaria, and WHO. Of course, this was initiated in high burden, high impact countries. And of course, we are seeing that more countries are choosing this initiative because this is a key element for malaria elimination. And of course, this can be used also in low malaria transmission settings. So because the key element is the use of data to target and tailor malaria intervention, as well as cross collaboration and political will. So this those are the elements for all malaria elimination. And of course, as I say, it's based on resources. We first prioritize where we have the highest burden and then continue to the lowest malaria transmission. This can be used in all the transmission settings. Thank you.
Thank you. I think we don't have much time anymore. So before we end the session, I would like to request our eminent chairs, Lady Roslyn and then Madam Jaya, to give closing remarks, please. Lady Roslyn.
Thank you. Well, I'm not going to sum up because we've heard so many different aspects of this important issue about use of data, how to reach vulnerable populations, problems of finance, ongoing finance. I will make a comment about the financing. Yes, I think we should stop saying we only reached $15.7 billion. In the current environment, that was a remarkable achievement. And when we look at the OECD figures that just came out last week on ODA, between 21 and 22, there was a decline of 11% in real terms in ODA. So for the Global Fund to have increased from 14 to 15.7 billion actually was a remarkable achievement. That doesn't mean to say it's enough money. It's not enough money. And we have to continue to find more money and, as Dr. Karema was saying, use money far more efficiently. Thank you.
Madam Jaya, please.
Thank you all the distinguished panelists and the moderator for this excellent session that you have had. I think it was very well moderated and the three panelists have put forth their views on all the three major points that you had asked. You had kind of requested them to talk about. I think what came through was, one, do more with less, whether it is resources, whether it is personal resources, I mean personal or human resources, or I will add that, or with the kind of financial resources that we are talking about. But at the same time, we all brought out that the community resource persons would be probably the key to elimination of the disease. And there I think we need to put in more resources. Maybe some of it could be voluntary work, maybe some of it could be in terms of certain remunerations, which would be not perhaps financial from the malaria point of view, but there could be certain spin-offs of those. So we may need to look at things a little more innovatively. Maybe look at whether there could be some kind of services that are given in exchange for voluntary work that are done, or some credit points for certain items. So these are the kind of things that probably we need to look at. And then there was also this issue of data management. I think that's really the key, because if we need to plan for elimination of malaria, then the hard data, where it is, how it is, to the granular level, not merely a very generic or a generalized kind of data, but to the granular level, so that all our efforts could be concerted and concentrated in those through these intersectoral collaborations and coming together that we are talking about. Thank you so much for bringing all of these things so very well in this very short time. Thank you.
So this is the end of the panel discussion. I would like to thank the chairs, the panelists, as well as the distinguished delegates. So over to Vimi, please.
Yeah, thank you to all our panelists. Thank you to the honorable chairs, all the panelists for the insights and the very valuable learnings which you shared with us. May I request the APLMA team to please join us in expressing our gratitude. So esteemed thanks to our honorable chairs, thanking Ms. R. Jaya. Thanking thanking Lady Roslyn Morauta. Thank you, ma'am. Thank you to all our panelists. many thanks to our moderator. Thank you. A group photograph for all our speakers, and we close the session. So thanking in the audience also everyone, all of you, for your active participation. We are now going to be moving into a short tea and coffee break of 15 minutes. 4 o'clock we start with the last session, the last technical session. It's therein we have the conversation of 60 minutes between Dr. Anup Anbikar, Dr. Philip Velkov, Dr. Kamini Mendes, moderated by Dr. Sarthak Das. That's going to be at 4 o'clock. Please join us for tea and coffee being served outside, and quick one there, and then back at your respective seats so that we can have this next session on time. That's going to be the last knowledge technical session, and then we'll have a short closing session, a wrap up with connecting the dots in the evening. Ladies and gentlemen, at 7 o'clock we also have a cultural evening giving you a little taste of India with its dances. Thank you. Enjoy your tea, please.